Welcome everyone to our deep dive into the world of gastritis and gastropathy. It's a really complex topic, covering everything from definitions to diagnostic techniques and treatment options. Let's start with the basic definitions, shall
Yeah,
we?
sure. So the material distinguishes between gastritis, which typically refers to microscopic inflammation of the stomach mucosa, and gastropathy, which covers non-inflammatory damage, right?
Exactly. There are different ways people define gastritis. Some use the symptom complex, some say an abnormal endoscopic look, but this work prefers the microscopic inflammation angle.
Got
And
it.
what's interesting is that histologic inflammation doesn't always match what you see endoscopically.
Right. They even pointed out that in about 14% of patients, you can have histologic inflammation despite a normal looking stomach on gastroscopy, and vice versa.
Yep, which highlights the challenge for clinicians. It means a normal endoscopy doesn't necessarily rule out gastritis, and it leads into why biopsies are so critical. Typically, you'd want two biopsies from the antrum, one from the incisura angularis, and a couple from the
Right, that
corpus.
level of sampling helps correlate clinical data with the pathology. Speaking of pathology, the chapter divides gastritis into acute and chronic, correct?
Yes, and that's a key distinction. Acute gastritis, which is rare, involves a dense neutrophilic infiltration and is mostly due to invasive infections. Think phlegmonous or even emphysematous gastritis, serious conditions that can lead to gas gangrene of the stomach.
I've heard emphysematous gastritis, for instance, can show gas in the stomach wall on CT scans. It's a critical situation. And then there's chronic gastritis, which is much more common. Often it can be asymptomatic, but is significant as a risk factor for ulcer disease and even gastric cancers, especially when linked to Helicobacter pylori infection.
Precisely, HP gastritis is central in chronic cases. It's described as causing a persistent active inflammation where neutrophils and chronic cells like lymphocytes are both involved, even though, interestingly, many infected patients never show overt symptoms.
Yep, that's fascinating how the infection just persists silently in many cases. Let's talk a bit more about Helicobacter pylori itself. The chapter really outlines its properties in detail, doesn't it?
Absolutely. HP is a gram-negative spiral-shaped bacterium with flagella for motility, which help it navigate the gastric mucus. It produces urease to neutralize the stomach acid, splitting urea into CO2 and ammonia.
Right, effectively creating a mini neutral pH microenvironment so it can survive. And then there's the whole issue of virulence factors like the CAG pathogenicity island, CAG-A, and VACA, which essentially mediate the inflammatory response in the host's gastric epithelial cells.
Exactly. HP's CAG-PAI is like a molecular syringe, injecting its molecules into the cells and messing with cellular signaling pathways. It activates NF-κB, for instance, leading to cytokine production like IL-8, which recruits neutrophils.
And that cascade is a big part of why we see chronic active gastritis. However, I did wonder, sometimes it seems that even with this robust inflammatory response, HP can persist indefinitely. How do you think the bacterium evades complete clearance?
That's a great point. Despite the inflammatory response, sort of an immune system paradox, HP has many mechanisms to evade immunity. It interferes with antigen presentation and even produces factors that mimic host molecules, which might trick the immune system.
I see, so it creates a kind of tolerance despite the ongoing inflammation? Fascinating stuff. Now, shifting gears a bit, what about the diagnostic techniques? The chapter discusses a wide range of tests, right?
Yes, they cover both endoscopic and non-endoscopic tests. On the endoscopy side, you have the biopsy urease test, which is fast and relatively inexpensive. It relies on the urease activity of HP to change the pH of the medium.
Right, though we have to be careful with that test if the patient is on PPIs or has blood in the stomach, since that can mess with its accuracy. And then there's histology with special stains like GEMSA and even culture, though culture is generally more challenging.
Exactly. On the non-endoscopic front, serology is common because it's convenient and inexpensive, but its positive predictive value is low in populations with low infection prevalence. So, the urea breath test and stool antigen testing are more reliable,
And it's
especially
crucial
after
not to use
treatment to
serology
confirm
after treatment
eradication.
since antibodies can persist. Speaking of treatment, there's quite a bit on managing HP infections, quadruple therapy, and even rescue treatments for cases where the first line regimen fails.
Yes, historically, the classic triple therapy combined a PPI, clarithromycin, and amoxicillin for 10-14 days. But because of increasing clarithromycin resistance, especially in areas where resistance is above 15%, bismuth-based quadruple therapy has gained favor.
And some guidelines even recommend 14-day courses regardless, right? And they also mention options like sequential, concomitant, hybrid, and even levofloxacin-based regimens for rescue therapy when the primary treatment fails.
And here's an interesting tidbit. The material emphasizes that prior exposure to macrolides, like clarithromycin, really limits the effectiveness of regimens that include it. So if a patient has taken a macrolide before, alternative strategies should be considered.
Absolutely. And that's where it's critical for clinicians to take a detailed antibiotic history. Now, one area where I might question a bit, in some discussions, they mention metronidazole resistance as an in vitro phenomenon that's overcome in vivo. Don't you think that might oversimplify the issue given some recent evidence suggesting it can actually affect outcomes in treatments, especially sequential therapy?
That's a fair challenge. While traditionally metronidazole resistance was thought of as relative and partly overcome by higher doses or combination with bismuth, newer data does hint that it might in fact lower efficacy in certain regimens. So really, individual resistance patterns could be more important than we once believed.
Right, it really underscores the need for personalized treatment strategies. Beyond HP, the chapter also dives into other infectious causes of gastritis, from viral agents like CMV and HSV to bacterial infections like tuberculosis and even syphilis.
Yes, exactly. For instance, CMV gastritis usually occurs in immunocompromised patients and can mimic a neoplasm on endoscopy with thick hemorrhagic folds. And then there's syphilitic gastritis, which can produce that hourglass appearance on imaging and dense plasma cell infiltrates on biopsy.
They also cover fungal infections like candidiasis or the lethal mucormycosis, and even parasitic infections like anisakkidosis from raw fish ingestion.
Right? It's really a spectrum. And then there are the distinctive forms like collagenous and lymphocytic gastritis. Collagenous gastritis is associated with subepithelial collagen deposition and can cause anemia or epigastric
And
pain.
lymphocytic gastritis, which is marked by dense intraepithelial lymphocytes, is sometimes seen in HP infections as well as in patients with celiac disease. And then we have eosinophilic gastritis, which, although rare, can present with significant GI symptoms and is often part of a broader eosinophilic gastrointestinal disorder.
Absolutely. On another note, the chapter doesn't just discuss inflammatory changes, it also talks about reactive gastropathies, a sort of non-inflammatory damage response. This can be due to medications like NSAIDs or even bile reflux after surgeries.
That's a really important clinical point because the management differs substantially from true inflammatory gastritis. Speaking of bile reflux, they even mentioned how bile reflux gastropathy can lead to intestinal metaplasia and possibly raise gastric cancer risk over time, even recommending surgical modifications like Roux en Y limbs in some cases.
Yes, it's incredible how diverse the etiologies can be, from stress ulcers following major trauma all the way to radiation gastropathy, which can occur both acutely and chronically.
And let's not forget graft versus host disease, where apoptosis of gastric epithelial cells is the hallmark. Another complicated area is the hyperplastic gastropathies, like Menetrier's disease, that's characterized by giant cerebriform folds, protein losing gastropathy, and even an increased risk of cancer.
Exactly, and it's often linked with overactive EGF signaling. Some cases even respond to targeted treatments like cetuximab.
I recall hearing about that. It's a promising approach, but still requires more trials. And the complexity here really reinforces the point that these conditions are multifactorial. Each subtype of gastritis has its own clinical implications.
To wrap up, the material covers not only the morphological and pathological spectrum, but also the public health aspects, like the epidemiology and transmission of HP, including how socioeconomic status and household crowding during childhood drive
Yes, it's
infection
amazing how
rates.
factors like water quality and even family clustering play significant roles. And finally, the discussion of treatment guidelines is really comprehensive. They break down first line treatments and rescue regimens with detailed tables that consider antibiotic resistance patterns, even mentioning the use of urea breath tests for post treatment confirmation.
Exactly, it emphasizes that successful management isn't just about treating the infection, but also about reassessing and ensuring eradication, because persistence could lead to severe complications like peptic ulcers and even
Right,
gastric
so a
cancer.
rigorous follow up program is essential. This has been such a deep and engaging conversation. I must say, although the details are extensive, the overarching theme really highlights the need for precision in both diagnosis and personalized treatment, especially in the face of rising antibiotic resistance.
Absolutely. It's like every biopsy, every test, every treatment choice has to be made with careful thought about the underlying pathology and the individual patient's risk factors. And as our understanding evolves, so too must our strategies for
For sure, it's
managing
a
these
field that's
complex
constantly evolving with new
conditions.
molecular insights and treatment protocols. Well, that was an excellent walk through the multifaceted world of gastritis and gastropathy. Thanks for this engaging discussion. It certainly shed light on all these interwoven topics.
Thanks to you too, it's always rewarding to break down these complex issues and see how everything fits together, even with all stutters and little interjections that remind us it's a human process. Until next time, keep questioning and stay curious.